Morning. I'd like to call this meeting to order. First, I'd like to acknowledge that TNRD, we connect with many First Nations communities across our vast regional district, and today we are located on the Tecumseh-Secwepemc territory, situated with the unceded ancestral lands of the Secwepemc Nation. The TNRD appreciates the partnerships that we have with the Tecumseh-Secwepemc and respect the territory and land on which we gather today. Any additions or deletions from the agenda? Any movers? Moved by Director Middleton, second by Director Smith. All in favor? Thank you. And we have a set of minutes in front of us with a recommendation. Moved by Director Hall, second by Director Sarai. All in favor? Thank you. Next we have a presentation from the CEO, Christine Machuzik, from the STEPS Clinic. Christine?
Great. Thank you, Chair, and thank you to the committee, the board here today. So we're here to do a quick presentation. My name is Colin O'Leary, and I am the president of the board for STEPS, which is a nonprofit society. And I'm going to give you a quick presentation if we can just load it up here on the side screens. And as Mike has already introduced, I have our lovely CEO, Christine, with us to also be here. Christine's going to answer all the tough questions because I'm just the board chair, so I'm here to look pretty. It's mostly my job. Thank you very much. Okay, I will proceed to the next slide. If we can do that, or should I try? Aha, love it. All right, so we're going to give you an overview of STEPS. Some of you have heard about STEPS, and some of you haven't. So we're going to tell you what this is, what we are. So STEPS was incorporated as a nonprofit British Columbia Society on April 11th, 2017, with the idea to create and lead innovation in primary healthcare. I was part of that small group. We are like-minded people, a small handful of us, really. I think there was 4 or 5 of us at the time. And we were sick and tired of seeing all of this struggle in primary healthcare. And we knew that there was a better way that this could happen. So our goals was really to demonstrate some world-class examples that we could bring to Canada. Why are we not learning from around the world? Why are we not doing better in primary healthcare? There's so many people without a family doctor. And this has been there. It's been a problem for a long time. So what we did is that is the purpose, was really to demonstrate a successful model to show that we can do primary healthcare better. And by demonstrating it, we were going to then teach others and have it scale. And so we're a nonprofit, and we've always done this in a model of basically sharing openly with other communities and other entities, including our ministry and our health authority, to say, listen, this works. So replicate what we're doing so that we could affect larger system change in primary healthcare. And it's really a very audacious goal, but as you'll see as we get into this, it's been a number of years later, and we've actually experienced quite a bit of success. So the idea, what we've put forward, what we run are community health centers, the community health center model. And there's lots of examples around the world of this, and it's different than what you'd find in a typical family doctor's office. We're also a learning organization, and we collaborate a lot with a lot of different organizations in town, including the Community Association, or the Canadian Association of Community Health Centers, the BC Association of Community Health Centers, TRU, UBC, the Thompson Regional Division of Family Practice, Ontario Health Authority, Cumsting Health Society, Doctors of BC, and many more. What are we doing right now? We have operationalized 3 clinics within the TNRD, and I don't know if you know that we run these or not. We actually at one point were even larger. We've right-sized ourselves recently with some of the pay model changes that have happened. So we currently are delivering healthcare, our little nonprofit, to 14,000 people in the region. Family doctors, that's what we do. That number has been as high as 20,000 people in the region that our tiny little nonprofit is helping serve. And we do this by supporting a team of more than 50 patient-facing providers, including family physicians, general practitioners, nurse practitioners, and allied health and social providers. What we do is we innovate and we share knowledge. We enable others around BC to develop and implement successful community health centers just like we've done. And we've helped a number of communities throughout BC. We do all of this for free. Family physicians, general practitioners, and nurse practitioners are really the backbone of our operation. And they make up the majority or some key components of our team. But besides that, we have supporting patient-facing team members, including registered nurses, social workers, clinical counselors, registered psychiatric nurses, respiratory therapists, dietitians, diabetic nurse educator. We've had other healthcare providers as well. This is how a community health center is different from a typical family doctor's office. By having this team-based support, we are ensuring we are providing the best care possible for people. And we're also making sure that we don't have doctors necessarily as the limiting factor for being able to support patients. Because we're making sure that we link them, they are the center of their healthcare journey, and we link them with the most appropriate healthcare provider. Team members supporting all the other work include medical office assistants, billing experts, clinic managers, and directors. Other team members include locum students, residents, medical students, volunteers, and others. We have done some fantastic work with TRU and UBC, to name a few. We've actually been recognized outside of BC for a number of these initiatives and within BC. So what populations do we impact? We serve the general population, women, children, Indigenous, and people requiring urgent care. So STEPS strives to provide the urgent same-day appointments and booking regular appointments within 3 to 5 days. Access to care was one of the core pillars of our strategy from the beginning. We have achieved this. How many of you can see a doctor, your family doctor, within 1 day if it's an urgent thing, or book a regular appointment within 3 days? This is the sort of stuff we have to get people out of emergency rooms, because that is very expensive, and a lot of people who are in an emergency room are not there for an emergency, and they're clogging that system up for the people that need it. STEPS provided 59,498 patient visits between June 1st, 2023 and May 31st, 2024, to put some numbers to it. And we've diverted 3,335 patients from the emergency department for urgent care concerns between that same time period. What are our challenges? Why are we here today? We're here today for a number of reasons. First of all, the Thompson region, as you well know, we have a deficit of community medical space and infrastructure to care for our population. There are numbers that are thrown out there, and I've heard them as high as 50,000 people in our region without a family doctor, which is mind-blowing. We have a shortage of family physicians and other professionals to care for people. STEPS, our operating funding is continually challenged and strained with our nonprofit business structure. We have built this from the get-go off of a loan from Community Futures for $260,000 that we went out there and we got. And then we were lucky enough to get a grant from the Stollery Foundation. That is what we have built this from. And we have every year struggled with operational funding, and we don't want this to implode. We need help. We need help to keep delivering this care so that we're not suddenly gone next year. And I can tell you, things have gotten close. Like, some of you know my history, my background, but right after actually my house burned down and I was temporarily in accommodations, I remember I talked to Christine and I was like, you know what, like I think I have to step down from this. I put thousands of hours of volunteer time into this, and it's too much. And you know, the whole team, they're amazing. They just basically were like, you can't, like, we need you. We're changing people's lives. But during that time, do you know that our bank account got as low as $8 to cover payroll? And I was scrambling around town for an emergency loan. And I was not sleeping at night because I didn't want to have to tell all the great people at Community Futures or the staff. I was going to personally deliver a message to all of them that that we let them down. But we didn't. We survived. And we've had bumps like this. That is how close we are to disappearing. And it's as painful to me that it's such a struggle when we're impacting people's lives so powerfully. And we've really proven that we can do a better job with primary healthcare. So that is part of the reason why we're here today. It's just to raise awareness about what we're doing and these kind of challenges. And, you know, we're governed by a volunteer board of directors. I think this is super important. We are not financially driven. We are people from our community that care about our community. That is critical to this model being successful. We are not making numbers based on the amount of profit I'm going to get in my pocket. I put in thousands of hours of volunteer time into this, and so have other directors. And we do this because we want to make the community better. So we need your help. And part of the reason why we're here is to increase awareness about what we do. We have some announcements coming up that are going to be fairly exciting, but we do need help and we need support to make sure that we can continue to deliver this care and maybe even expand it into the future to help more people in the TNRD access a family doctor like they all deserve. And so one thing we would love to throw out there is the idea of possibly a task force or a smaller committee to start talking about what could a longer term vision look like where we're collaborating more closely together. So that's the end of the presentation today. I'm sure you probably have a lot of questions, and that's why I brought Christine, because she's way smarter than I am, and she actually runs all the clinics, so she has all the answers for you. But so I'll turn it over to the floor for any kind of questions if we have time, Chair.
Thank you for that presentation, and thank you for everything you have done for the community, and we expect with your announcements that'll be coming up, everything you're going to be doing for the community. I suspect we'll have some questions here. We have Director Getz and Director Sarai and Director O'Reilly.
Thank you, Chair. Thank you for the presentation. I just have a couple quick questions. My love for the medical system is renowned. You're talking about community medical space and infrastructure. When you talk about medical space, what are we talking about when you talk about that?
Yeah, thank you. When we talk about that, what we're discussing is that we have a population of about 135,000 people. The average one FTE of family physician time takes care of about 1,250 people. We don't have enough medical space for medical professionals when they're ready to easily transition into a space and start up a practice. So that's largely what we're talking about. So zoning could be a consideration, the space itself, how it's set out, designed. The medical space traditionally has limitations. And so moving through the pandemic, we started virtual care. We started a number of different ways of delivering care, and the spaces have evolved. And so we're looking at even things like accessible spaces. The majority of family practices don't have a lift to be able to take somebody out of a wheelchair. And as a direct result, that person faces barriers to care, full physical exams, a number of different things. So STEPS is considering what does that look like from a justice and social perspective overarchingly, and what do we need to do collectively to be able to create the spaces to support the people to do their best work in caring for the people in our cities and towns.
Okay, so I'm just going to run this by you and call me crazy. It's fine. In my town, or my city, we have a hospital. I think we have 46 beds. We use 8. Why could we not use the rest of the hospital for something like this where we heat it and light the entire building, but we use like 10 rooms? I'm just wondering if there's a push or we've ever considered that, because like I say, we've got all this empty room that just sits there and gathers dust.
It's a fabulous idea, and I think that is the way that we need to look. Schools might also be an opportunity as well. And yeah, sky's the limit, but definitely we need to be more innovative and thinking about outside of the traditional boxes. And the business model definitely could include those types of spaces.
Because I think taxpayers know that they're paying for an entire building, but only a fraction of it is being used. So, okay, thank you. Something to think about. Thank you very much.
Yep. Maybe I'll add as well, just really quickly. Sorry, I'm obviously a lot louder than Christine. It's really tough. Healthcare is very complex as well, and the hospitals are a very different animal than primary healthcare. But I think that's part of the reason why there's not the best communication between them. But I think that is a very good idea. I just wanted to throw that out there and make sure not everybody knows those differences.
Thank you, Director Sarai.
Thank you, Chair. Thank you, Colin and Christine, for that presentation. My question is probably on the same line. How intertwined are we with interior health? So when you're diverting patients from emergency, which is helping the hospital do their job, how funding wise, resource wise, is there an annual intake from interior health to help you? Because that to me would make sense. Instead of coming hand out every year trying to survive, you're actually helping the healthcare system as a whole function. And I'm wondering why they're not at the table.
It's a lot of politics. I think the short answer is no. There's different parts of money for different things, but there are opportunities. In the past, we have had very similar ideas. And quite frankly, we've engaged in a lot of conversations over the last 6 years, and there are struggles on that front, and we would love to get there. There is as some of you are probably aware, there's this primary care network initiative that is rolling out. That might be one of the first opportunities we're going to kind of see to really be able to maybe access a little bit of operating capital to support us and some staff time. But largely in the past, I think a lot of it is the structure of funding and politics, quite frankly. It's been frustrating for me very much, I can tell you that, over the years, but Christine is much more gracious than I am.
Supplemental.
So just on that, and you're in the right room for politics, I think if there's anything we can do moving this forward, because it's for the whole region and it's for the residents, healthcare, let us know if there's anything we can do to assist you to make this a year-round, long-term investment that you know is going to be there for the residents.
You know what? That's fantastic. That would be our dream coming true, actually, honestly. And that's part of the reason why we're here today. And you know what? Quite frankly, by giving us this opportunity, you're already helping us, because we have been so head down doing working our butts off as staff, that we haven't done a great job of getting our message out there about us and what we do. And a lot of people are actually patients of our clinics, and they don't even know it. And so we're going to work on getting that message about us out there, because that'll increase that advocacy and awareness, and I think will help pull political levers. But we would love to go with what you talked about. And I think maybe this task force idea, that was kind of the path we were going down, is figuring out what makes sense. But thank you.
Thank you. I'm next on the speakers list, but I didn't mention that we do have 3 directors online, Director Sao, Director Demare, and Director Birch Jones that are joining us virtually. Thanks to you for the presentation from both of you. And really for me, when I had first heard about STEPS going back numerous years ago, I thought it was a bit of a pressure relief valve. That this is going to be great. This is going to help us get through to the next stage where we're going to have more family doctors. Unfortunately, it's, to me, now not a pressure relief valve, but it is a key pillar to healthcare in the TNRD. And I say unfortunately because I wish it didn't have to go this route, but thankful that STEPS was able to step up and fill that void. And it would be hard to imagine the TNRD with 15,000 less residents without a family doctor, as we all hear about that now. So thank you very much for everything you do and everything you've done to get to this point. I just a question for yourselves and then one to staff after. Just going through these steps, has Interior Health and has the Ministry of Health, have they been supportive and a partner, or are you almost working in a silo on your own trying to make this work? Because when I hear $8 left in the bank account, that's not a number I've heard in any medical funding conversations I've had over the last 6 years. And so that to me is fairly jaw-dropping. So if you could comment on that, thank you. And this is the political table, so you're at the right place.
I can speak, we have a board, so I'll speak mostly on my own behalf, but I can tell you that there has been I felt a lot of frustration. And the biggest thing is exactly what you've all immediately identified, which is that if we could get commitment on sustainable funding, especially for operations, it would be really helpful. But any kind of sustainable funding like this, so we could commit and plan. We have a huge problem. So our discussions in the past have not been great, from my opinion, with Interior Health. And there's been a lot of struggles with something that's called the Collaborative Services Committee. Things have gotten a lot better recently. I think they're getting better. But in the past, there was a lot of what felt like kind of roadblocks and really complete lack of progress, actually, quite frankly. And I mean, we've tried to talk a lot about what we are doing, and we have not ever really received that support. And we've literally been demonstrating that we are achieving exactly what the government talks about. And we've had many talks with all the way up to deputy health ministers. We've sent letters to Minister Dix. Minister Dix, by the way, when he comes to town, talks about our clinics all of the time. And it's funny though, we invited him to tour one of our clinics, our Orchards Walk clinic, and he didn't have time, even though the meeting was literally happened in the Orchards Walk Senior Center. And I found him, by the way, later on roaming the streets, walking around. So I get frustrated by some of this stuff because I'm saying we are literally checking these boxes of what you want to do. We're trying to share it and expand it. What is the hookup? And I think there's a complex system. I think there are some silos that are out there. It has been very frustrating. I can tell you, I've spent like probably hundreds of hours in meetings, and some of them on the weekends and the evenings even of my own time, working through some of these challenges. And it's very, very, very frustrating for me. But I can say that things are getting a lot better. Recently with some changes, they are on the right path. But we would love to be able to get some of this. And we have an announcement that's going to be coming up that is going to be the first time ever in the history of STEPS that's going to be able to actually help us a little bit on this front. And it is actually money from the ministry that will flow through Interior Health to get to us, so that it is changing. But the reality of the matter is still, we are razor thin. I can tell you that with our finances. And, we would also love to be able to pay our healthcare providers even more to be competitive. So part of our operating model is we actually shave off a percentage of their billings to be able to kind of cover overhead and cover what we do. And we didn't actually cover this in the presentation. I'm realizing we've been doing this for so many years. The other thing STEPS does is we run the business and the clinics. That's what we do. We look after the staffing. We look after the legal stuff. We look after the lending. We look after all of this stuff. So our doctors can come in and they can just be doctors. And you know what? It is so powerful hearing from them as well, because they are like, this is what I signed up to do. I did not sign up to be an entrepreneur. And a lot of them struggle with that. And that's why you see a lot of doctors leaving primary healthcare, because that has a lot of additional work on their shoulders that they are not cut out nor trained to deal with. We take care of all that. And then with some of that money that we shave off, we also get all this allied health support, which you don't typically see in primary healthcare. And that's where we get to deliver like high quality, high access primary healthcare. And we didn't invent this idea. This has been around for ages. We're just doing it in BC. So sorry, kind of a long-winded answer there for you, but there you go.
No, that's all right. And thank you for your perseverance on this. Question through to staff. Legislatively, I mean, for what we fund more capital projects and equipment. That's more what we do. But I guess my question through to staff, I don't know who would be best to answer, and I see you all looking. But really, if we wanted to shift some funds, typically right now our funds flow through Interior Health, and that's who we fund with a partnership with them, a certain percentage. But if we had funds that we want to direct to another medical agency, I guess is the best way to maybe describe this for capital funding. Is there anywhere in legislation that allows us to do that, or do we have to funnel all our money through Interior Health, or are we allowed to start exploring and looking at other things that we fund that we think would be best for the region?
Thank you, Chair. So I can tell you that in the Hospital District Act, which of course this board is constituted under, you've got the purposes of a regional hospital district, which includes establishing, acquiring, constructing, reconstructing, enlarging, operating, and maintaining hospitals and hospital facilities. It doesn't specify the manner in which that has to be done, and there are societies which engage that in other places. So for example, there's Providence in the Lower Mainland, there's Nishka Health Authority in the Northwest that are societies that are funded through the hospital district. The one caveat I will put on is that it does need to be hospitals and hospital facilities which have been designated by the minister under Section 49 of the Hospital Act. And so, for example, I know that in last year, the Columbia Shuswap district, I believe they had to request the designation of one of their facilities so that they could provide it funding that they wanted to.
Great, thank you for that. And I appreciate that answer. I think there's a lot more research to do if that's something we want to go down, but we'll save that for a future meeting. The speakers list, I have Directors Middleton, Smith, Hamer Jackson, Birch Jones, and I believe I have Director Getz as well, and Director Robin Smith. So we will go to Director Middleton.
Thank you. Thank you for the presentation. STEPS is a nonprofit. Are you also registered charity? Can businesses or individuals make charitable donations to your society? And if not, are you attached to any charity that we could potentially make a donation to with the specification that it go to something like STEPS?
So STEPS does not have charitable status, but we have a close agreement with the Sun Peaks Health Association to start having conversations about what that could look like. So we're hopeful in the future that we'll have that ability, but no, not today. Mhm.
Thank you. Director Smith.
Thank you for your presentation. As you know, probably the majority of the TNRD is rural. So I just want to know what your vision is going forward to be able to provide better healthcare in the very rural areas.
Ideally, everybody would have access to a family doctor or a nurse practitioner and be attached. We have lots of conversations, and I was actually on a call with the Rural Coordination Center yesterday with a number of different people from rural BC, all over rural BC. And the conversation was around how does the community health center model support rural communities in particular. It is a fabulous community-driven, nimble way of delivering healthcare services. And so it's our desire to share that. If we could step into that space and operate in smaller places, I think our board would consider that. Currently, we have 2 clinics in Kamloops and 1 up at Sun Peaks, so we are operating in a rural community. We have some understanding of the challenges and the nuances and how to go about doing that. We do believe that there's sustainability in team-based care. Also having that network and that collegial support is really critical. So when we talk about maybe environmental wildfires, disasters, things like that, we're often planning about how we redeploy our services in the event that patients and our service providers have to evacuate. And so we have technology and we have connections all over BC that if our team did need to go to other places, there would still be access to virtual care. You could still phone the same phone lines and access somebody. So if you needed prescription refills, or you had an urgent concern, or you had labs or diagnostic results that were coming back and needed an answer, and there was an urgent concern, somebody would be following up. And we purposely have designed steps to be able to be nimble, but also react and be sustainable when we have people facing really big challenges, because doctors and our team, they do face big challenges on occasion. And so that sustainability in a system, a strategy, a strategic approach is really important to the work that we do.
Thank you.
Thank you. Director Hamer Jackson.
Yeah, I think a lot of my question has been answered, but up until this point, how much participation has been from the provincial government, and no matter what ministry? And also, what about any grant funding or anything like that? Like, I thought maybe I missed something, but I think maybe I hadn't. So maybe you could answer that.
Yeah, so STEPS is a member of the Canadian Association of Community Health Centres and the BC Association of Community Health Centres. The BC Association of Community Health Centres was formed in 2017, the same year as STEPS, and we participated as a member. We have sat on their board of directors in the past as well. That group or that organization meets regularly with the primary care division and the assistant deputy minister on our behalf. And so there is lots of advocacy and conversation happening. We are seeing strategy funded community health centers starting to materialize throughout BC. Hopefully we have some good news in the very near future for Kamloops as well. Specifically, STEPS has some good relationships and good connections with specific ministry employees. And so we are working, but it's a very slow process.
So we just got to put the gas on a little bit, I guess.
Thank you. Director Birch Jones online.
Thank you. I really appreciate what you're doing and hearing about it, but I'm listening and thinking what you're doing sounds so much like what the province says it's doing in terms of primary care and team-based care and so on. I'm from Lillooet. I just wanted to mention that we also, like one of the other rural areas, have a very underutilized hospital. We used to be a very busy hospital providing all kinds of service, and it's extremely limited now. There's an opportunity there I just wanted to mention, but also Are your clinics still accepting patients? Are Lillooet folks? Because Lillooet is a central place for, or Kamloops is a service center for us. So do you consider you're serving the whole region? And I apologize for coming in late because you probably covered that already, but I heard 2 Kamloops clinics and 1 at Sun Peaks. And I should also say just thank you. And Chair Riley asked all the questions I had written down. So that's it. I'll stop there. Thank you.
Yeah, thank you. So we provide longitudinal care for about 14,000 people right now. We also provide a women's and sexual health service and urgent care services to people who are attached or unattached. Currently, in BC, the urgent primary care centers are supposed to be funded and rolled out by health authorities. So there's one in Kamloops, and we've been told that's their responsibility. We do provide urgent care for our attached people living in Kamloops. Up at Sun Peaks, we provide urgent care for anybody attached or unattached. And so we have rolled out that design within our organization. We also have medical services and a contract with Quemstein Health Society. So we have we provide medical services. Our doctors go to Quemstein and work as part of their team, and we work quite closely to ensure that those members and those people of those communities have access to medical care. However, we can work together to best support and deliver that service. We also have medical services that go to Bonaparte and provide care, and those people there are able to access care in our clinic or in their community when our people go there. We don't have capacity right now to take on more patients. Again, Colin mentioned that we're right sizing. We only have 3 clinics. We're hopeful in the very near future that we'll have more space and that we'll be able to attach some more people. But at this point, we have access for people who are women or having sexual health challenges out at Orchards Walk, and we have that information on our website, stepshealth.ca, and a patient can phone and book in there. And then up at Sun Peaks, if something happens up there, people can walk in through the patrol and our health center and access medical care in that way as well.
Thank you. Director Getz.
Thank you. In our community, we have a group led by the First Nations community, and it's they're building their own clinic called Schwackham Health. And I'm wondering, they've managed to get 2 doctors in, and by this time next year, we'll have 5 doctors. And the clinic is open for everyone in the community. I'm just wondering, have you tried to partner with some of the First Nations and some of the things that they're doing? And I was just wondering, or maybe you're partnered with these guys already. I don't know. We'll find out.
That makes me so happy to hear. And yes, so we have a service agreement with Quemstein Health Society, and their board of directors is made up of Skeetchson, Whispering Pines, and Kamloops. We're also very connected with the 3 lakes, so Adams Lake, Squilac's, and Esconlith, in supporting all the things that we can possibly support. There's a larger conversation happening or starting to happen around the primary care network and what that could look like for Indigenous people and leaders as well. So that's very exciting. There has been the idea brought up of what does Indigenous-led health services look like for Indigenous and non-Indigenous people collectively. I'm quite excited about what that could look like, and I think it's a huge win for everybody. Thank you.
Thank you. Director Smith.
Thank you, Chair, and thank you very much for your presentation today. I visited your booth at the UBCM, and I talked to a colleague, I think she was from Trail, and they were in the process of setting up the community healthcare model in their clinic there. So I'm not sure where they're at in that process, but it sort of piqued my interest because I'm the mayor for Logan Lake, and we've had challenges over the years with retention of physicians and the rollover, and then that obviously creates issues with patients becoming unattached on about a 3-year turnover. It sounds like you guys are almost going to a model that existed many years ago in our health center, where we actually had a community board of directors that was responsible for the healthcare center itself. So I really, really like your model because I like the fact that it actually takes into consideration the residents within the community and what their needs actually are. So I'm definitely interested in exploring further, and I very much appreciate your presentation today. You've done a phenomenal job. Thank you.
Thank you. Director Hamer Jackson.
Just gonna say thank you. And my mom worked at the D&T years ago, so yeah, yes, small world.
Yeah, I just had a quick question. How's your staffing? Do you have are you having any problems staffing, getting nurses and physicians and that sort of thing?
So definitely there's a shortage of physicians across BC and across Canada right now. At this point, we are fully staffed. All of our spaces are, we don't have any additional space, and actually we've got too many people for the spaces that we have. We train residents, so our doctors in our group of family doctors and nurse practitioners, we do a lot of training, and so quite connected in that way to new learners. We've also got a very stable group of Canadian medical graduates. So there's different training programs for physicians in BC. There's the Canadian graduates who graduate with a full licensure and no return of service requirement. There's international medical graduates that are trained overseas. They do their residency here. They graduate fully licensed with a 2-year return of service. Then there's practice ready assessment or PRAs who are trained overseas. They do their residency overseas. Then they're assessed in BC for 3 months, and they get they have a supervisory requirement with a provisional licensure and a 3-year return of service. Those return of service positions are often what end up being allocated to rural places, and that also, I've heard that about 95% of those people end up leaving at the end of their return of service. And so that results in that turnover. So it's, yeah, it's quite challenging.
Supplementary.
Supplemental.
So if we get more facilities open, are we gonna have a problem in staffing them, I guess is kind of what I'm getting at. And do some of the restrictions that we have in British Columbia on who can't work, does that make a difference also?
I was in Toronto 2 weeks ago, and everybody's talking about BC and this new longitudinal family practice payment model and how doctors are leaving everywhere else. I don't know yet. I'm very hopeful that the new family practice payment model has made a big difference. Certainly, it's made a big difference for our team, and I think that the payment model is very much more attractive than it has been in the past. I still think that it is challenging and daunting for a new graduate to think about opening their own business and laying out the money when they've got $200,000, $300,000, $400,000 worth of debt coming out of their medical school. I think the community health center model where they can step in and start practicing and not have to lay out a huge amount of money, with having support, being able to be away, being able to have kids and a family and be off if they're sick or their kids are sick and know that their patients are receiving care. It's very difficult to operate a medical practice when you're on your own. And so I do believe that BC is well on its way to solving that challenge. But again, it is a national challenge. And so what time will tell, I'm hopeful.
Thank you very much and great work. Great
Thank
work.
you. I'd just like to add a few things as well. Christine is very modest, and there's so much we could tell you about STEMS, but she has actually done a phenomenal job, and we work very closely with Heidi Coleman, who's on our board as well, at attracting physicians. It is extremely hard to do, and the model's attractive, but Christine has been phenomenal at actually bringing a whack load of doctors into our region. And the other thing too, when we talk about that health, I'm glad we talked really quickly about that training of medical doctors. Our mission is just to increase access to healthcare in the region. So that is something that's actually more of a cost to us than anything, but we do that because it achieves the goal of just bringing more trained doctors into our area. They don't have to be our doctors. We are fine with that. We've also done stuff like prevented certain clinics from closing. And so that's something we don't talk about a lot. Like the ministry very much wants additional attached people is really a lot of their metrics. I always want to point to them, you know what, there's another side of that equation, and that's plugging the holes for the ones that are closing. And so we've been very effective at doing that as well. And I think we got to look at the holistic picture there. And also just want to speak to the fact of the nimbleness. This goes back a little earlier. Christine was talking about that, wildfire evacuees. For example, this isn't just an idea. So they mobilized within, I think, a week to be able to actually provide access for all the people that were evacuated from Squil Axe to Secwepemc with that fire last summer through our Sun Peaks Health Clinic. And it was done like that. The Women's Sexual Health Clinic, we found out that was a need, and we didn't realize that had been a need for something like 10 years, I think. I'm going to get all these numbers wrong. Christine's probably dying behind me, but it was a need for a long time in our region. And when we identified this, within basically 2 to 3 weeks, had it up and running for people that weren't even our patients, everybody who had that need in the region. We've done stuff like we supported the obstetrics. Did you know that? Through COVID, when there's problems at the hospital, we stepped up and filled the gap for obstetrics. And again, no additional payments, nothing like that. We're doing it because we're filling needs in the community. When COVID first happened, they had a drive-through COVID vaccine set up within, I think, a day, probably like 16 hours. So like the nimbleness is our power. We are not these slow-moving government bodies. We are very nimble nonprofit society that can adapt very quickly, innovate, demonstrate that it works, and we fail too. But we learn and we tell other people about our failings. And we've been very good. For example, like just more recently, Vernon was interested in our model. They came up here and Christine took a couple of days, or at least a day, touring them through all of our clinics, teaching them everything. We share all of our resources with them. The original business plan I wrote myself, it's getting a little old now, but we share that open source for any community that's interested. So these are the sort of additional things we're doing to make a bigger, broader kind of impact. And yeah, we could go on forever, really.
Well, thank you. I see no further speakers, but thank you for coming in today. And as much as healthcare is evolving, I think it's our board as a job to stay educated on what's happening in our areas and in our region. And I really think this is an extension of that education as to how healthcare services are being provided in the regional district. So thank you for your time. And we're going to have a lot to go away. And I think we'll be thinking and talking a lot about it between now and our next board meeting. And we can go from there. But thank you so much for your time.
I was going to say thank you again to the board for allowing us this opportunity to talk about steps. We very much appreciate it.
Thank you. So we'll move on to 6.1 TRHD bylaw number 164, capital expenditure and borrowing. CFO Fox.
Thank you, Chair, through to the board. So I want to start at a place, I'm just going to bring up a slide from the budget presentation that was done back in March, just because with the report, the capital bylaw that the board has adopted has inferred that the board supports the cancer care project, which requires us to access funding. So although we wouldn't access all the funding up front, the regional district borrowing is a bit different than the hospital district borrowing in that we don't have to do a referendum. We just need ministerial approval. Essentially, in contact with MFA, we need a bylaw supported by the board, which they accept. So it might seem for someone new like me in all of this, accessing $45 million by way of a bylaw without referendum might seem different, but that's the way that the hospital district board is set up so that they can address those large capital items. When you approved of the 5-year financial plan, during the lead up presentations, I did a number of presentations in regards to the impacts on our residents. The plan that we had put before you and that was approved with the 5% increase year over year was really to address the cancer care project. Everything else in the operating budget was essentially staying status quo. So I'm going to bring up a slide that shows you the impact on taxpayers, just to give you a refresher on what that was, so that you know what we're moving forward and accepting. We would only access temporary borrowings as we need it as the project's going along. We're not going to access all the funds up front. But I think it's a very good proactive approach to make sure that it's approved and ready for us to access when we need it. Also, I'll go to the slide and show you those numbers. Sorry, I thought it was on that slide already. This one right here. So what this is showing is based on a home with the average value of $680,000, which is essentially the average of the whole TNRD. So just remember that that takes in a very large area, but it gives you an idea of what the taxes were and what the increase has been. So for 2024, we would have started at 2023 at $204 per resident of $680,000 per year. With the increase in the budget presented, that is going up to $210. So because there's a large population that pays into this, even though it's a larger increase in the budget, the actual increase per taxpayer is $6. Over the 5 years, by the end of the 5 years, the compounded increase is about $33. And that is what it would get to over the 5 years so that we can maintain paying back that debt and principal or debt principal and interest owing. So I wanted to not get too deep into that, but I wanted to give you guys that information as a refresher to why this is coming. This is already in your capital bylaw approved and discussed during the 5-year financial plan. Hence, this is a process that we have to do to access the borrowing with the Municipal Finance Authority, which is who we do our borrowing through. Is there any questions in that regard?
Before we go to any questions, if there aren't, I just want to clarify that for a regional district or municipality, it's a referendum or an alternative approval process. It's not just a referendum as an option. And for funding for our large capital projects, and including the patient care tower and the parkade and the 2 levels above, those were all done through the ministry. So I'll just leave it at that. Thank you. Any questions on 6.1 or the presentation from CFO Fox? Okay, in front of us, we have 3 recommendations. Do we need them in? Oh, sorry, Director Stamer. Director Bass.
Okay, thank you. I remain extraordinarily skeptical about this. And I have some questions that will influence how I vote on this because I've been thinking about it a lot since being used as a prop by the provincial government a few years ago. I have questions about the clinic. Would that be appropriate? I'd like how it's going to operate. Would that be appropriate now or should I wait?
Don't think CFO Fox really has many answers on the operational side on the clinic, but possibly when Interior Health takes the microphone in 7.1, you may be able to dive more into the details.
Could you put me at the top of the question list for that, please?
Thank you. Director Stamer.
Thank you, Mr. Chair. To Ms. Fox, I'm just looking at the breakdown here, and when we're looking at these totals, knowing that this is going to be slated for build in 2024, are any of these progressively designed builds? Are these going to be etched in stone built? Like my question is, you know, is this going to be a design build approach on what we're talking about with the parkade and going forward, or are we going to be looking at the new progressive design build approach, knowing that we don't have control over that, but is that what's going to occur? Because I have a supplement if.
So I actually am not going to be able to answer that question. I don't know if there's anyone here that can answer that question for me.
I'll provide some latitude to your health if you're willing to answer that question, or if not, that's okay.
Thank you, Chair. Good morning, directors. That is in my presentation coming up. I could touch on it now, or if you just, it'll roll out naturally when my time at the podium comes.
That's fine, Mr. Chair. I'll wait.
Thank you.
Director Grenier.
Thank you, Chair. Just wondering if there's anything in the documentations or approval of this series of things that commits us to additional costs. Is there anything that if we took the stand that this was the limit, are we able to take that stand?
Thank you. I think that's a good question based on the history of what's kind of happened over the last couple of years. So it is my understanding that they have given us their best estimate of what they believe the costs are going to be. I think that the board could make a decision that based on the numbers put forward and the numbers that you approved in the capital bylaw, that would be the maximum. And, you know, at some point, if they were down the path that there was cost overruns, there would be an expectation for them to make sure that they engaged with you as that was approaching, and you could make a further decision at the time. But as far as this is concerned, it's based on the numbers that were brought forward by Interior Health. And they're the numbers that we have to work with if they're looking for cash flow to start this year.
Thank you. Supplemental.
Well, yeah, thanks, Mr. Chair. Just wanted to make a point too, as our experienced and distinguished Mayor Rain has mentioned in the past, is that number one, we don't get involved in the design process whatsoever. So if there are any cost overruns, we have to suck it up. And number two, why are we constantly having to pay extra over and above when there's other taxpayers in other regions of this province that don't have to? I think that's a kind of an elephant in the room here. And it's one thing to be supporting a budget for a proposal like this, but are we going to be continually being asked year after year after year to be contributing to these healthcare facilities when other regions in the province do not? I think that, you know, somewhere along the line, we should be saying, look, we're all in this together. Why should we have our taxpayers paying more than taxpayers in other regions for this? So maybe I'm the only one that feels that way, but I don't think it's fair.
Thank you, Director Stamer. And from what we have in front of us today is the bylaw that's in front of us. And believe me, I think we've had this discussion many times over the last pushing 6+ years on this same thing. But it is a very live conversation. And obviously it did come to the forefront through the emergency room overruns as well. But what we have in front of us today for this board to make the decision on is the 3 recommendations today. And certainly that's a much bigger conversation. But I have Director Roden, sorry, was on the speaker list.
Thank you, Chair O'Reilly. Given the fact that there was a massive cost overrun, $40 million on phase 2 of the RIH project, and the hospital board's share was 16 million, I think we all understand cost overruns are a fact of life. What took us all aback was the fact that this cost overrun and the bill for 16 million was presented out of the blue. And I'm wondering if there's anyone who can answer a question which I asked twice of Minister Dix at a press conference earlier this week. He gave a very fulsome answer both times to a completely different question altogether. So I'm wondering how we can be assured that as this project progresses, the hospital board will be kept fully apprised of any cost overruns as they are occurring or anticipated, not after the fact you owe us $16 million.
Thank you. And I guess I'll speak to that a little bit. Couple of things. One, the MOU has really changed things with communications with Interior Health for projects in general. But specifically when we were talking about the cost overruns for the emergency room, we were very clear from the TRHD that wasn't acceptable, that can't continue going forward. And it's a good working relationship that we're able to lay these things on the table, and things that we need as a board and what our expectations are have changed. And with that MOU, it also helps us to get that. I am confident in that. I do meet with CO Hildebrand with Interior Health at least every 3 months minimum, and depending what happens to be on our agenda as a board or Interior Health, and we have these conversations and dialogue back and forth. We don't always agree on things, but nonetheless, the communication channels are much better, and I would expect them to be for this project going forward. But I certainly hear your concerns given how things have been done in the past, and it's hard not to look back on the past. I am trying to look forward. I'm an eternal optimist, but I do believe the communication has improved, and I think Interior Health feels the same way, and they may talk about that when they speak in 7.1. But thank you. Anybody else for Director Getz?
I guess this would be to you, Chair. Do we With the concerns of what's happened in the past, how come we do not have somebody from the board in the planning design and sitting, getting information to bring back to us as we move ahead with these things? So we don't get caught short. I'm just curious.
Yeah, I mean, that's historically has never happened before. We have, myself and CEO Hildebrand are meeting with Susan Brown coming up in July, and that may be something, hearing that that's something that may be worth discussing, we can have that conversation. And, but again, I hear that concern, and that's something that I can address if that's what the board so chooses. Director Sarai.
Just some clarification, Chair, with the dialogues going around the table and not trying to put any emphasis on what I'm about to say, but can we table this till after the presentation?
If that's the will of the board, we can. At the same time, this is something that we do need to address and get across. We know that this is a long lead time between where we are now and when things are going to actually happen with the facility. And I think there's going to be a lot of conversation with Interior Health through the board, but as well as the oncologist that will be working in the upgraded facility and the new facility. I don't think this is a here you go and we're done. I think that the conversation will continue, but certainly I serve at the pleasure of the board if that's something you so choose.
Like to put a motion forward to table this till after the IHA presentation?
I'll second that.
Moved by Councillor Sarai, second by Councillor Newstater, and I just want to reach over to administration. I see them sort of huddling, and I'd like to get comment. Thank you.
Thank you, Chair. The point was purely on exact terminology, but what I'm looking at is in section 12.2 of your hospital board procedure bylaw, which states a change to the prescribed order of business may be directed by resolution of the board. So however you want to phrase it, whether it's tabling, postponing, whatever, I think the motion is that this matter be postponed at this point and then picked up again after you have heard from Interior Health at 7.1.
Thank you. So a friendly amendment just to postpone until immediately after 7.1.
I agree.
Okay, yeah, okay with the seconder. All in favor with the motion? Opposed, if any? That's carried. Thank you. Oh, sorry, Director Lepso. Sorry, Lepso is opposed for the record. Thank you. And I do need that screen drawn down for the online people, please. Thank you. There we go. If I could just get a yay or a nay on moving this to 7.2 for the people online, directors online.
Yay.
Great.
And Director Birch Jones, you were muted if you did say yay or nay. Oh. That's great. Thank you. I'm good with that. Okay, thank you for that, Councilor Director Sarai. We will move on to 7.1, and that's Royal Inland Hospital update.
Thank you, Chair. Good morning, directors. I think my slide deck is just coming up here as we speak. Thank you. I'll start off by recognizing and acknowledging we're collectively gathered on the traditional, ancestral, and unceded territory of the Secwepemc Nation, where we continue to strengthen our relationship with First Nation, Métis, and Inuit people across the interior. Chair, with the benefit of the conversation leading up to this, my first item on the agenda is an update on the Phil and Jeannie Glardy Tower Phase 2 budget. I'll walk through that. I have an update on the Kamloops Cancer Center. I think Chair probably makes sense to stop for questions after the second bullet, and then I'll move into the third item, which is an update on projects by community, which is the first time Interior Health that we're bringing that type of information to the board. We'll walk through that, and I hope it'll be of benefit to everybody. So phase two, significant renovations are happening. 2024, this year is a heavy year in terms of work happening within the pre-existing structure, South Tower, as we like to call it. We're on target to complete the project by fall of 2026. Jerry, when he steps up to the podium, he'll have a bit more detail in terms of where we are on the individual items within phase two and how it ties to operations and staffing and so forth. In terms of the budget, phase two renovations, as we discussed back in at your March meeting, originally 53 million was what we had budgeted for in 2016. That in order to to do the exact same things we originally envisioned within the phase two budget or the phase two project, 54 million additional is what we need to do it in today's market. We came before that, we made some changes within other areas where we could shift where we could, as well as we had a $10 million project reserve contingency, which went towards the phase two pressures as well. In the end, 40 million was the net pressure that we talked about and brought to the board as part of our request in March. The board declined. We worked with ministry. Ministry is providing the full 40 million for us to continue with the project without any major changes to the scope of work. So we're on our way. Again, 2026 is when we're looking to complete, and Jerry will have some more information available in terms of the what's going to be happening when. Definitely heard the conversation ahead on the communication that was not adequate on our part. We heard that. We will not make that. That will not happen again. That will not happen on the Kamloops Cancer Center project. Lots of things in hindsight and looking in the rearview mirror on it. I can tell you completely, this was not us trying to withhold information. It was a very hectic time with a lot of people trying to get a handle on why and what could we do about it. The year flew by on this project as we were trying to manage that and trying to come up with solutions. We thought at the very beginning of the year, okay, maybe we just need 12 million more. The 12 turned into 40. In the end, delaying further any of the items that were in the phase two scope of work. They were all critical needs. It would just be more expensive down the road. That's where we're at. I can assure you, we'll be communicating regularly as we move through the Kamloops Cancer Center project. Will not be in this boat again. So in terms of the Cancer Center project, an update on the procurement side of things. Question in terms of how we're going to procure. So the new facility, which is the cancer where radiation will be taking place, radiation therapy, as well as the MRI facility and the parkade, that part of the project will be procured through a fixed price for that new construction. In terms of the work and upgrades within Royal Inland Hospital to facilitate the chemotherapy and our pharmacy needs, that will be done through a construction management process. So very similar to how we work with phase two, we have the same risks. I don't think we have the same conditions we had in phase two in terms of the timeline, much more condensed. Hopefully no pandemic happens between now and when we start that part of the project as well. That is how it is progressing though. Two components, fixed price for the new build, construction management for the renovations inside. Announcement was out earlier this week. There are two teams that have gone through the qualification stage and are moving on to the RFP stage for this work. Alice Dawn Corporation and PCL Constructors West Coast Inc. We expect by May of next year to be able to make the final selection and conclude the RFP process with construction beginning in the summer of 2025. We're at a $359 million budget. We're still working within that. But coming this summer, we will need to be updating our costs based on moving further along in the design work and working with the two proponents. We'll have more information at your next meeting in September, and ahead of that time through your CAO and through Chair O'Reilly in terms of how that costing refresh, what it entails and what information we get from it. And just a reminder on our target completion dates for the new facilities, December of 2028, and the upgrades at Royal Inland Hospital will follow in the summer of 2029. There was one question in terms of the cancer center that came out of the meeting in March. That's around the parkade and how we came up with that initial split in terms of use of the stalls, 20% for the cancer center and 80% of the stalls for Royal Inland Hospital. There's 470 stalls in total, 92 identified for the cancer center. We did have a parking consultant as part of the project. On average, there'll be 87 employees in the cancer center for the PHSA side of the work. And just so happens, on average, 87% of our staff park on site. Remainder get their other ways, public transportation. So the demand for our staff in the building is 76. In terms of patients, on average, there'll be 19 patients in the building at any one time. Slightly lower average at 84% is what we've determined from our experience at Royal Inland for patients in RIH would be parking on site. So 16 stalls for our patients, and that's how we came up with the 92, and that ties into the ratio at the beginning. Again, maybe before I go through the updates on projects, Chair, is there any questions on either Glardy Tower Phase 2 or the Cancer Center?
Thank you. I have Director Bass and Director Stamer. Director Bass.
Thank you. Questions on the Cancer Center. To my understanding, having had to research cancer centers, well, let me put it this way. If somebody needs chemo and radiation, are you expecting them to walk across the parking lot?
Gary, if you could help me on that one.
Yes, with this build, the radiation, so sorry, Jerry Desley, Executive Director, Royal Inland Hospital. The radiation and chemotherapy is separate. Radiation is the Cancer Center in the new build, and the chemotherapy would be in our con clinic in the main building.
So then you are expecting them to walk across the parking lot?
Correct.
Okay, second question. Does BC Cancer run the chemotherapy clinic? Because I noticed you say it's going to be provincial health for the radiation, and that's not IH. And I may have a supplementary depending on the answer to that one.
Yeah, so the radiation center would be run by PHSA, so BC Cancer. The con clinic, so the Community Oncology Network Clinic, is run by Interior Health as it currently is. The Comprehensive Cancer Center is what is run by PHSA.
How do two health authorities work together to ensure patients get the best cancer care? Like PH is going to be running radiation. IH is going to be running cancer. Do you guys talk to each other? Do you have systems in common? I mean, I'm just picturing unhappy cancer patients.
Yeah, we do. We have, through this whole phase, we've been working very closely with BC Cancer. So this is a joint project between BC Cancer and Interior Health. So we're working together. We have, at this time, daily meetings as we're going through the RFP process and updates with it. So we're working very closely with them. I think this is similar to other models where all the con clinics in the province are run by the health authorities and not BC Cancer. We do meet with them regularly to have conversations and help with, make sure we're all on the same page with how we're delivering care.
Supplemental.
Okay, I'm more familiar with the Kelowna Center. Is it not all run by PH? Like I'm just struggling here with two health authorities that I'm not a big fan of health authorities to begin with. And you obviously know that from our conversation before, but I'm just struggling with conflicts in technology, conflicts in staffing, who's going to be coming here to work in the radiation thing. I'm not seeing a seamless flow for cancer patients.
Yeah, I think it might be a little early to answer those questions as we're really working through the project and how to build and the things we're looking for in the design phase of it with those groups that are the two companies coming forward with the RFP. So
I think as we work through the workflow and how that works, I think we'll work through that. The Kelowna Cancer Center is different because it is a comprehensive cancer center that's run by BC Cancer, not Interior Health. But there is a lot of even connection with Kelowna General Hospital with surgeries, and even our ORs at RH with surgeries, that there's a lot of those connections with patients that they often are going between different health authorities and getting some care with BC Cancer and some care with Interior Health or other health authorities. So that is fairly common practice for us to work through that, and we ensure that good communication and things are happening. And again, as we work forward through the actual work plans, as we get farther along, we would have more of that planning, but this time it's really about the connection on the redevelopment phase in the buildings.
Thank you, Director Bass. Director Stamer, and then Director Hamer-Jackson, Director Sarai.
Thank you, Mr. Chair. Thank you very much for the presentation so far. That's good news that you've decided to go with a design build and the progressive design build. We could have got into some of the discrepancies in how everything is going along with the new progressive design builds. They're supposed to be, you know, way more efficient, but honestly, every single one across Canada has been way over budget. My question to you on the RIH upgrades, in looking at the schedule, it's 76.8 million, and our portion is just under 27 million. Can you answer why we're going to go with the construction manager, even though I know there's still some uncertainties with renovations because of those cost overruns at the last go around, which were significant? Why wouldn't we want to be able to go with a more of a design build on the renovations so we'd have fixed costs?
Thank you for that question. In working with our engineer and design consultants, they've advised this is the most practical, the lowest cost approach. The amount of risk a contractor would build into that portion of it. Again, the challenges of working inside a hospital, doing a major project that's running at the same time. We do our best to cordon off the areas that they're working in, but there's always, you know, that daily integration. The amount of risk that they would build into their bid is greater than that they would see in us taking the risk now on, in essence, doing it at construction management, which is, you know, several, it could be dozens of different individual contracts. That's what they're telling us. The risk is there for sure. We do not believe we're going to have the same experience we saw with Patient Care Tower, going from 50 to over 100. Again, the timeline is much more condensed here than we had with Patient Care Tower. We think that, you know, the market is much more stable than what we saw at that time. And we've learned a few other things as well, and communication with our funding partners is definitely at the top of that list as well. That is the where we're at, Director.
Supplemental.
Okay, thanks for that. So I guess my question is, should we be building in a separate contingency on this, or do we have your assurances that if there are any surprises, they'll be brought to our attention, as you alluded to earlier in your presentation, and not sort of slid in under the carpet?
We believe in the 359 that we've come up with. We've got our learnings in that number. There's going to be an update coming for us this summer. We will be sharing that as soon as we can. We believe we've covered that off in the 359. I guess we will know sooner than later how close we are, and then we'll just. I think we just need to take it step by step from there.
Thank you, Director Hamer-Jackson.
Yeah, I'm not sure if I've missed something, but if we know the percentage of or the number of lack of parking spots right now, and moving forward 15 or 20 years from now, are we going to have enough parking spots available, you know, for the future, or are we going to have to do something else?
We believe the 470 is going to cover our growth based on what we're seeing for services now and the volume growth. we have been off on volume growth in the past, or other things have changed to inform that. We are not done at this site by any stretch over, or at this hospital over the time to come. I suspect there'll be other parking projects that'll be a component of anything else that we do to expand the site. But in terms of adding the cancer services and what we have there now, the additional 470 stalls will cover us till we actually change services again.
Okay, that's supplementary. That's,
Supplemental?
I'm wondering, do we know right now how much lack of parking we have by percentage or parking spots? Is that all?
We added the gravel lot where the new cancer center will go. We will have other parking spaces that we're going to continue to have available for staff in the adjacent neighborhoods. We'll keep those through the construction through 2029. And we'll relook at things at that time. But based on our best information, we should be good with the 470 stalls at completion.
Thank you.
Thank you, Director Thorpe.
Thank you, Chair. I'm going to ask a really simplistic question. Why aren't we putting everything in the new building? We have a blank slate, chemo radiation pharmacy. Wouldn't it be more cost effective? You'd have a clear projection of costs, and it would be a lot more patient friendly when they're already dealing with the trauma of cancer, having to go from one side of the site to the other, people getting confused. Would it not be simpler and more cost effective and better for the patients to put everything in that new building?
So those alternatives were looked at through the design process. Jerry, if you can help me on that one.
Yeah, I think there's different costs you need if you're having everything together. Part of the renovations is redoing the pharmacy and expanding that. And the location where the clinic will be moved to on the first floor, it would be on the same unit, on the same area. So that piece coming in together. If you're putting all that into the new building, you need to expand all of that in it. So you need pharmacy in the other building. You need to expand everything, and you're kind of doubling up when we're just, kind of across the road. So that was looked at as what that would look like, but really looking at, to look at cost to look at expanding the site, meeting RH needs as well as the cancer needs, having that proximity basically on the same floor across a hall was seen as beneficial to that. And appreciate, yes, it is walking across to the other site, but the reality is there's a lot of pieces that go into that. And
Supplemental?
Did you look at the cost differences? And
me
what were the
yeah,
differences?
me personally, no, it was part of the project team.
Did anybody look at those cost differences? And do you have an idea of what the differences were, given that you don't know exactly how much it will cost to do a refit?
It was looked at. It was early on in the design stage that we came to the conclusion chemo will stay where it is because of the adjacency to pharmacy and several other areas, to move all of those over to the new build. In terms of the cost differential, I do not have that available right now. I could take that away and come back.
Thank you. The speakers list, I have Director Newstater, Roden, Grenier, Getz, and we will go to Director Newstater.
Thank you, Chair. Thanks for being here and answering tough questions as we try and learn from the past and do the best we can in this partnership to land where we need to. We do appreciate that. I'm just following up on Director Stamer's question. I was curious, you said we've got that covered in our number when talking about contingency and what we might need to plan for versus what you have planned for. Can we hear a little bit more of that? Because I think the board would be reassured to understand that that past learning has resulted in contingency being built in, but I think we'd feel more comfortable if we could have that quantified in some way to understand what we might need to do to ensure that we don't have added numbers on the back end. So can you expand on your comment that we've got that covered in that number?
I could share that number through to your staff and to your CAO. Wouldn't, for tendering purposes, wouldn't want to share the exact number here, but we can share that with you confidentially.
I think that would be helpful. Thank you.
Thank you, Director Roden.
Thank you. Just a simple one. Thank you very much for acknowledging and the miscommunication in the past, and thank you for committing to improving that situation going forward. I was very happy to hear that, and thank you for taking that responsibility. It's not as common as we would like to think it might be.
We can do better.
Thank you, Director Grande.
Thank you, Chair. Thank you for the presentation. We're considering this request for 45 million. What if that was all that was coming from this area? How would you change, or would you keep on the same path? Because you're in charge of this. You're doing the design build, the fixed price on one side, something else on the other side. We're just the funding agency. So can you tell us if there would be any difference if we said to you, it's just 45? That's what we can come up with.
So we've worked through the process. If it comes to light, the 359 is not enough. Our first path is always to, again, we look at the scope. What do we have in? We look, is there things that we could change and basically first and still largely deliver the product? So those are your finishings. Is there nice to haves that we could maybe do without, or look at a different way to do it? So that would be the first step we would take if the 359 is not, turns out to be not sufficient. If in the end, after going through that process, we still need a funding, we have a pressure that we have to deal with, that's when we start working with, we would work with the ministry, and that's where our commitment is to work with you to, it would be initially through your chair and your CAO, here's where we're at. And then gauge the next steps. After that point, Chair, I really can't speculate, but those would be the first two steps we would take.
Supplemental.
I'm just wondering if the process would be that we're committed to $45 million, and just as you found a solution to the overruns in the second phase, that you would go to those people to solve that because they're intimately involved with this process. We're sitting here on behalf of our constituents committing to $45 million and all the numbers that CFO Fox put up there. We're not saying to them, oh, and there could be some more coming. We should be telling them if it's more coming. I think that what our thing today is that we can agree to $45 million, let you run through your process, let you run through your design. And then if you feel that you need more money than the 359, go to the province for that, but don't come here. How would you respond to that?
I can't respond any different than I did initially. I'm sorry.
Thank you for those answers. And I'm, before Director gets here, just a couple of questions. And I think ultimately we have a long runway in front of us of how this is all going to operate. But a couple of concerns that I have specifically around drug navigators, to ensure that we have those in place for the patients receiving cancer treatment and how they're going to proceed forward. And as well around the actual, we've talked about the renovation for the pharmacy, but pharmacists not being watered down and diluted, a specific cancer pharmacist or oncologist pharmacist being important to how the actual treatment that the cancer patient is receiving. And I respect you may not have the answers now, but certainly that's conversations that have come up.
Yeah, I can't speak to it specifically now, but I think that's as we work through more with BC Cancer and looking at all the staff we need to support this, we would have more answers in the future of what that would look like.
Thank you. Last on the speakers list is Director Getz.
Thank you. Just a quick question, looking at your parking situation. My wife and I use this hospital twice a month, and we go through the find a parking spot game. And I'm wondering, with the 80% for Royal Inland Hospital, for your staff, would you be working towards some sort of incentives as carpooling or transit, some sort of incentive to help them free up spots so we can get more people in the parking areas? And I'm just wondering if that's something you've looked at.
Yeah, we do look at different things, also ride to work ideas, so more bike options, things like that. We're trying to get people obviously out of cars and getting more of those other activities, but do, of course, want people to carpool or do different options. And we really do try to police the public parkade or at least, make sure staff aren't parking there, to make sure there is spaces for others, and try to share that really the patients are the ones that need it, that often aren't able to walk up the hill. It's hard being on the side of a hill, and those spaces are really for those. So we do patrol it regularly and follow up with people if they're not parking appropriately.
Thank you. Seeing no further speakers on these first, Director Houghton.
Just a quick question, kind of an overview question, not really pertaining to this, but with the shortage of land that we have within the city of Kamloops and the expansion, doesn't matter if we're going to build a hockey rink or what we're going to build, land is tight within the city boundaries of the city. What is our long-term viability on the footprint of land that we have at RH for the future, the next 50, 60 years? Where are we going to be? Do we have enough land at our present location?
I can field that one because there's really not one firm answer. But what I can tell you to Director Houghton is we do have phase 3 of the Royal Inland Master Plan. Right now with the Phil and Jenny Gillardy Tower, that was phase 2. The next phase 3 will be in, and don't quote me on years, but maybe 13 to 15 years is when it may open. So there is a long-term plan. Outside of that, I would leave that to Interior Health or the provincial government, but we do have quite a bit of time in front of us with the allotted space. And it includes demolishing some older buildings on the Royal Inland campus for phase 3 and reusing the existing space we have more efficiently. Thank you. I will pass over the next 2 items. We have staffing recruitment, long-term care beds. And just for the directors themselves, we do have lunch coming at noon today, just so everyone knows. Thank you.
So, Chair, I'm good to go on to the updates on projects. Thank you. Before I get started on this item, this is the first time us bringing this information to the board. It's a commitment that we've made to all our HDs through our MOU is to an update on projects. Other hospital districts, just through tradition and how things evolved, we've been doing this for quite some time other places. So although maybe new for the Thompson, not new in terms of how we do it in other places, but we're getting to a common point. In terms of composing this project or this report, we had to come up with, well, what would be our starting point? How far back do we go? So what we've landed on in terms of what I'm going to report today is any project that we haven't notified your staff, your CFO, that the project is closed and complete. There's several on here that we'll note as we go through that are complete. When a project is complete and we've advised, reported to the board, we will then drop it. You won't see it complete on multiple reports. And just a reminder again, in terms of how we work and how we bill on a project, if a project comes in under budget, and there are a few that actually do, we bill based on the actual cost. So if it's 100,000 below, you would get you would be 40,000 less on that project than what your bylaw states. If a project's over budget and we've come back to the board and they've approved the overage, then in essence the budget increases and we work through the same way. We do have some projects that do go over budget that we do not ask the board for support on, and in those cases the health authority covers that fully. So some of that will come up in the as I walk through this report. Open suggestions in the end or in future meetings on this report as well. I guess away we'll go. So starting with Royal Inland Hospital, for the most part going oldest to newest in terms of the projects listing in each of the areas, and the other facilities and other communities will follow. Highlighting the on time and on budget. Green is good, red is off, and yellow is in essence a warning and that we're working through things. I am starting with Royal Inland with the first 2 items, which are we calling them P3 maintenance obligations. Really, in essence, it's a commitment we've made with Ellis Dawn as they're working through phase 2. There are some things that have come to light that are outside of the phase 2 scope that just make sense for us to do while they're going through. We've had 2 amounts that this board supported for $1 million each. We are working through those, so we are slightly delayed, but because the project's delayed, but we still will be within the amounts that were approved on this. And then there is a third commitment, which will be coming to the board next year as part of our funding request letter for the final $1 million as part of the overall plan. The second item at Royal Inland is in our laboratory, chemistry analyzer and an immunochemistry analyzer, two that we're changing out that are linked. We have some stragglers, directors. This one started off in 17-18 as a $644,000 project. It was lifted in 21-22 by almost 500,000, and Interior Health has put in additional dollars on our own to get it across the finish line, not quite 1.4 million. The chemistry analyzer, that component of it is complete. The immunochemistry has been delayed due to vendor delays. They've actually had to redesign and rebuild their equipment for sale in North America. That has delayed us. So red, definitely not on time, and yellow on budget. We still won't know what our installation costs are until we get the final built drawings for it. We're hoping to have this project done in January. We have several projects coming up that are complete. So the pharmacy medication station replacements, phase 3 for Royal Inland Hospital, that's moving from what we used to call Pyxis to Omnicell. Those are the vending machine type of medication distribution systems. That project is complete, and we're in the process of going through the closure process and notifying your CFO. Below that, the renovation to the pharmacy at Royal Inland Hospital to meet the College of Pharmacy standards. That one had an initial budget of 1.5 million and from 1920, and then an increase of 2.8 million for a total of 4.3. We've got this project complete, and again, going through the closure process. Below that, the orthopedic surgery templating software help with joint replacement, for example. This is software that's shared amongst all the hospitals and all the RHGs where that surgery is performed. That project is now complete as well. The upgrade to the MRI machine. This one was where we originally requested dollars to actually do a full replacement. It became clear that replacing while we were going through the renovations really wasn't possible. We scaled it back to 2 million and did an upgrade in terms of the software and some of the component parts. That project is complete, and we're in the closure process on that one.
Director Stamer.
Yeah, thank you. Can you explain on phase 3 why that number is 3.4 million and we paid just about 2.2? Is that correct?
I may have a math error there. I do know you're at 40%, and that does not look like 40%. I will confirm that one for you. I suspect that is an error in my report.
Thank you. Proceed.
Sorry. Thank you. Okay, ventilation upgrade planning was the next item. Planning projects are a bit unique in terms of we come to dollars for the planning work. If we actually don't proceed and go to actually do the work, we credit back the amount spent because in the end, no asset was created. So that's just an overall statement. In this case, the planning work is complete. Several projects that we have, and they'll come up here shortly, where I've noted where we did flow out of this. So this is an example where the planning did come to fruition. The next item, upgrading 3 of the elevators at Royal Inland Hospital. This is a 1.9 million project where the foundation helped us out with 1.2 million and the balance was shared 60-40. That project is complete and we're in the closure process on that. The foundation doesn't always help us with projects that are really for building related, but we really appreciate their support on this one. Second last item on the page, a new microscope for ear, nose, and throat surgery. That one we've actually received the equipment. Training for our biomed staff who maintain that item is currently underway, and that'll be completed by the end of December. The last item on this first page for Royal Inland Hospital, another planning project for our laboratory, how we can, in essence, address our space issues in that area. We have a plan that after phase 2 patient care tower is complete, some adjacent space to the lab will become available where we'll expand out. And the completion of that will happen, the completion of this project will happen after phase 2. Okay. How come I'm not moving? Now I'm moving, sorry. Second page, final page for Royal Inland Hospital, starting off with the meal delivery system. So how we get food to our patients in the hospital. This project's been implemented and is substantially complete. There's some work we're still finishing up in the kitchen area, but we should be completed on this project in December. So the next item, air handling unit change out, 2 items. This project was informed by the planning work that we previously did. We're not moving ahead with this one, so it's canceled. We'll be giving back your money on the bylaw on this item, and there's another item coming up that's similar, and it does inform some of the HVAC related items that we asked for this current year, 24-25. The humidifier replacement, on this one, we're yellow on time and on budget in terms of the initial design has come in over budget. So similarly to I mentioned previously, we're looking at alternatives to try to do this within the total 180 that's approved. We have below that another pharmacy medication station. This is putting in those medication stations, those Omnicells in other areas of the hospital where we currently still have medications under lock and key. That project is complete and we'll be looking at closing it. Below that, medical imaging work area reconfiguration, a project that is complete as well. Below, next item is the electrical upgrade, another planning project. On this one, planning is taking longer that is anticipated. It will inform some of those P3 obligations that I talked about on the first page. We still will complete it on budget and we expect to have that done by December and then work forward from there on the electrical upgrades needed. Next item is the cooling tower sediment separator. Again, this project related to the HVAC system. We're moving ahead or we're not moving ahead. We found a different approach, canceling the project, returning the dollars. Next item, the operating rooms number 12 and 13, 2 operating rooms that we refurbished and re-equipped in the old tower. That project is substantially complete. We're using those rooms. We still have a couple stragglers in terms of equipment items being ordered. We should have this one complete in December. And the last 4 items are all new items from this fiscal year in terms of we're really just working on the scheduling of it. But the first 2, the heat recovery chiller and the HVAC handling unit, again, we're informed by those planning dollars that were previously identified. So that's the next 2. Second from the bottom, the pharmacy patient consult space project. That one will be moving forward with shortly, but we're working on the scheduling for that, as well as the reprocessors, the sterilizers for our endoscopy equipment. Other projects in Kamloops in community and primary care, the North Hills Diagnostic Center, the new X-ray center for the North Shore. That project is complete and we're looking at closing that project. The new substance use central health hub for the community on Lansdowne Street. That project is, we're yellow on time and on the budget side. Our initial RFP, we're looking to post in July. We quite expect the 700,000 will not be sufficient. So we'll be looking likely through design alternatives. Chair, more to come on this one. We're definitely committed to setting up this space. But our further design work as we move forward is setting up yellow flags in terms of the 700,000 being sufficient. Next item for Kamloops community is the administration staff consolidation where our accounts receivable folks are working in Sahali Mall. That project's complete and we'll be closing the project. The Kamloops North Shore Urgent Primary Care Center, which was on this year's request to the board, where the design is complete. We're out for tender on the construction for this project and hoping to be complete in October. Last one in this category, the South Shore Urgent Primary Care Expansion below the Parkade along Columbia Street at the hospital. This one is still in project scheduling. We'll have more updates for this one and on our next report. In the long-term care area at Overlander, replacing the cooler and the cooling tower projects from 21-22 complete. We're going to be closing that one out. Second item under long-term care, which was looking at developing a business plan for additional long-term care beds for Kamloops. This one, the ministry has not given us the approval to proceed on further planning. We've had lots of planning happening in Kamloops, around the Kamloops Cancer Center, so capacity has been a challenge, but Interior Health as well is, we're committed to relooking at our existing beds that we own and how we move forward in the future. And that's what those dollars would support. And then the last item under long-term care at Ponderosa is the emergency generator and transfer switch. That project, again, new for this year. We'll have a schedule for you at our next update. Moving into other parts of the district, in Ashcroft, the access control system, so in essence the card lock system, and implementing that for that facility. That project's from last year. Installation work is under the way, and we should have that completed and closed out by next March. In Barrier, replacement of the radiographic system, the X-ray machine. Directors on this one, both X-ray or both Barrier and Clearwater use the same equipment currently. They're bought at the same time. They're both at the end of life. Our plan was to replace Barrier this year and Clearwater next year. Clearwater is coming up with some parts issues that have affected its functionality. We're still able to use it. We're not able to use it for sitting or for exams where the patient has to lay down. We're using a portable X-ray to cover those off. We're also having some parts available issues at Barrier. It's still functioning, but not as functional as it needs to be. We've got the equipment on order for this item. There is a long lead time to get an X-ray machine sourced. We're going to be working through both sites over the summer to come up with what is our best course forward. We may need to request the board to allow us to, in essence, swap them out, move Clearwater this year, and then come back to do Barrier next year. We'll have more information in September on that one. In Chase, similar two projects, the access control system, card lock system, as well as the staff duress, the staff alarm system. We're moving forward on those. Installations take place here later in the summer and hope to have those complete by March of 25. Clearwater, the energy upgrade to the heating system. This project we initially asked at not quite 2 million in 21-22, and then needed a lift on that project in 23-24. So we're a little over 3 million for this project. We're at the 90% stage on the design. We're being reviewed for costing, hoping to go out for tender here soon, and looking to complete this project by September of 2025. Moving on to Lillooet, several projects there that are complete. Renovation of the medical device reprocessing system, the surgical information system. So in essence, we're doing the same charting for surgical patients as Lillooet as we are in other places. Can I get back there? Can you help me get back there? There we go. Okay, thank you. And both those projects are complete. The third item for Lillooet, which was a renovation to the main door system, we're actually able to do that work below the 50,000 threshold of capital. So in essence, we just expense the entire amount to operating, return the dollars to the RHD is how that one unfolded. The double door replacement, which is actually for the long-term care portion of that facility. That project work is underway, hoping to complete by October, as well as the steam boiler upgrade. Similarly, another X-ray replacement happening there. The design is complete. We've got that equipment ordered. Hope to have that done by January. Upgrade to the elevator system. This one, we're yellow on budget. We're at the 95% stage. We think we have a challenge in terms of living within the 339 total. We may have to look at alternatives here. More to come on that one next time I provide an update. And a similar story at Lillooet for replacing the nurse call system. We're at the 95% stage, and our costing at this stage is higher than our budget available. Last two items for Lillooet, the biomass penthouse burner access. That project, the design is complete. We're tendering. We should have it done by the fall. And the emergency room mill work, that project is just getting started. Coming to the end, Chair, Merritt, old project, the parking lot extension from 21-22 is complete. And 2 other projects, the chiller replacement and the bathroom renovations for Merritt were just approved this year. And we'll be moving into project scheduling here shortly. Chair, we'll be giving an update like this at least twice a year, maybe longer or maybe more if needed. There's several projects on here that were complete. Next time it will be thinner. I will be quicker. What questions?
Thank you. Before I go to the speaker list, I just want to thank you for doing this, and undoubtedly you're the person speaking here today, but I can imagine there was a very large team behind you that put this together. This has been something that this board has been talking about and asking for as long as I've been on the board. And so to see this, while it's incredibly important for our board as we're making the decisions and 5 years later it's happening or 4 years later, but our residents, to know where we're spending their regional hospital district dollars. This is incredibly important. And we have, people from the media that are able to get these messages out. This is what is being invested from Interior Health and the Thompson Regional Hospital District in your areas. It's not being forgotten about. We are spending to make healthcare better in partnership with Interior Health. And so I thought this was a very good thing for the directors. I think it's a very good thing for our residents. And I will start on the speaker list. I got Director Blackwell, Birch Jones, and Robin Smith. Director Blackwell.
Yeah, thank you, Chair. And thank you to the point on the Clearwater Hospital. I may have to wrestle Director Stamer for that X-ray machine. Yeah, my understanding is the community has already raised, I believe, $305,000 and is only short $45,000. So if there's a donor out there that has a spare $45,000, love to talk to them to get this a priority thing so that we could move ahead of barrier. Thank you.
All right, we got that in the minutes, I'm sure. Director Birch Jones online.
Thank you. And yeah, thank you, Chair O'Reilly. I agree. This is extremely helpful to see this report. And as I have previously, every time I see references to the surgical program in Lillooet, I ask, what is the status of that? Because the last few years I've been told it's on pause. And I recognize the speaker might not be able to answer that question, but I sure would like to hear the answer to that question. And I know Mayor Hopful is very keen to have our surgical program active again too. Thank you.
Sure, I could arrange for our next meeting to have an update on surgery at Clearwater. Definitely we need to support our surgical patients, our obstetrical patients in that area, but I'll have that for our next meeting.
Thank you. And I assume you met Lillooet there and not Clearwater, but that's all right. So we will go to Director Smith.
Thank you, Chair, and thank you for your report. I just wanted to point out that Logan Lake was not in there, and we'd love to see some upgrades in our center as well, because I think it's been a really, really long time since we've really seen anything significant, and we have definitely had a loss of service within that facility over the last, or erosion, I should say, of service over probably the last 10 years, including our blood analyzer that was funds were raised by the community for, and it never has ever been replaced for our health center. So I just wanted to point that out, and we hope we make your board.
Thank you for that, Director Stamer.
Thank you, Mr. Chair. And again, thank you very much for your presentation. I was here in January of 2019, and I think I was fairly outspoken at that time, looking for some answers to a wide variety of questions. And I think Chair O'Reilly explained it very well in as much as how much we appreciate the openness and the opportunity to be able to have these discussions and making sure that our residents feel a part of their healthcare facilities, because that's really what we're talking about. So thank you very much for that. My question is, would it be possible to get those long care bed inventory numbers by our next meeting? Is that something that you'd be willing to share with us and say maybe a 5-year projection on that? So as we go forward in trying to develop long-term care beds within our communities, we have a better understanding of what that need is?
We can. We can get something, at least a place to start. And Chair O'Reilly, maybe this is something that, again, between our discussions with your CAO and Sylvia and myself, that we can start to package it. But absolutely, we can bring some information, start the conversation in September.
Thank you. I don't see any, oh, sorry, Director Hamer Jackson, I have you here, but I forgot. Thank you.
You did, come on. Yeah, I'm just wondering, like, great work. I mean, you've got a lot of stuff on the go. It's obvious it's not an easy job, but I'm just wondering, you know, and this might be putting you on the spot, but how much more support could you use from the provincial government? You know, moving forward or even now, or are you getting enough? Don't mean to put you on the spot.
So we work with the province on all our priorities. Fishes and loaves is kind of my nutshell answer on that. The needs versus what we have available to work with as a system, they don't match. So we do the best we can with them. In the end, we work for the ministry. We take our direction there. But there is the ability for us to do what we're supposed to do, which is let them know what we're seeing on the ground. I think that's the best answer I've got on that one.
Thank you.
All right, I will hand over. Jerry does have a few updates to go through as well on a slide deck. Thank you, directors. Thank you, Chair O'Reilly.
Thank you. Jerry?
Great, thank you very much. First come up. My presentation will be a little bit different. Just kind of give more of an update on how things are going, not so much on, some updates on construction, but other things a bit more nebulous as far as staffing. And I talked to Chair O'Reilly a bit ago. He thought it would be good because there was actually some good news for RH and the rest of our communities. Perfect, thank you. All right. So don't be too stressed about the numbers. This is around our emergency department, and I just want to do a bit of an update of kind of where we're at. So the top line is a week between April 3rd and April 11th. You can see on there that often we are below 200. So our average daily patients through our emergency department RH was 208. You take 6 weeks later, May 15th to May 30th or May 23rd, you can see there was only 1 day below 200. The average on there is about 228 patients. So in a 6-week period, we're seeing an extra 20 patients per day. Our emergency department is extremely busy. We're seeing a lot more patients through it. We were hoping this would be a blip in May, but I think this is a bit of the new normal. A lot of patients are coming through. So just a bit of a idea of where we're at. This screen to kind of speak to some of the good news. This is our number of inpatients waiting for a bed, or the amount of time patients are waiting to get an inpatient bed. So you can see back in period 1, so that would be in April of 2022, 2023, it was almost 86 hours patients were waiting. We're now down to 25.8. So although we're not to baseline of basically every patient under 10 hours, we've made huge strides at our hospital to get patients out of the emergency department and into the beds where they need to be. So just wanted to share extremely good work by our teams to make that happen, and a lot of focused work on our patient units to get those numbers where they are today. Some phase 2 updates. This is where we are with obviously in a very exciting year and busy time with RH. So afternoon auxiliary to the RH post-anesthetic recovery room. Construction is complete and patients will be moving in on July 3rd. So staff are working to get that space ready as we speak. Beautiful new space coming up. As well, pediatrics, the construction is complete and patients are moving in July 23 of this year. The big one that our public will really notice is the phase 1B for our emergency department. It is be completing September, most likely having patients in there October of this year. That's the main public entrance, the new triage space, and the new horizontal zone to care for patients, which will take our emergency department about 2.8 times bigger than it currently is. Phase 1 of the morgue renovation will be fall of 2024. So just some pictures. Of course, pictures worth 1,000 words. This is the picture of our new post-anesthetic recovery room, some of the bays. So nice open, still have the windows for natural light, and be able to do some head walls across there, which was it was a bit of a construction piece, but it looks great now that we're in there. And a picture of our pediatric unit. So one of the rooms and the family waiting room, our pediatric unit provides care to outpatients as well as inpatients, and a very warm, welcoming space for those people, kids and their families to come in and receive care. So just a bit of a staffing update. Obviously, our rural sites are struggling with staffing. This is from my partners, Karen Cooper, but Blue River vacancies are being filled and we're in a better spot, hopefully to be a more stabilization there. Obviously, Clearwater has had a lot of challenges recently due to staffing. Really trying to work on that and get in a better spot. Lytton, the concept plan for the health services is going to set next week, our senior executive team for approval. Ashcroft, we've had all 3 physician lines are filled, and UPC are still some more time for people to get access. And Lillooet, they're down a physician, so we've been able to fill for July, but there is some locums needed for August to keep sites open. And I think many of you are aware that unfortunately with staffing, one sick call can lead to a closure. And as much as and as hard as we try to work to keep those open, that it does seem to move around. As we're doing a bit better in Merritt, Clearwater's struggling. So we're working hard to keep those open, and we totally appreciate the stress it puts on communities, and trying to do better with earlier communication as we've heard is sometimes last minute, but unfortunately sick calls do come in last minute that we try to fill and are unable to. This is again a bit of an update on, again, a bit of a busy screen, but this is just for our Royal Inland Hospital, new nurses coming into the site. So you can see from the very bottom, January to May in 2023, we hired 38 RNs into our site. This picture here on the left, the column is just RNs and RPNs that were hired and where they were from, for a total of 61. And the column on the right-hand side is the number of licensed practical nurses we've hired. So 72 new nurses to Royal Inland Hospital in the same time span that we only hired 38 the year before. So almost double the nurses coming in. So lots of work with our student nurses and getting them to come in. Again, this next slide is a bit busy. I don't focus on what the questions are. This is a snapshot of a survey we did with student nurses in 2022 compared to 2024. It's about 3 pages long. This one's just around the support the learners received. And there was approximately a 15 to 25% increase in all the responses in that survey all the way through it, and how we're supporting our staff. Simple things that, the staff knew my name. So lots of work like that. Simple things you'd think should be standard, but people were responded to as student come here. And now we have boards on the walls with their pictures, also pictures of our staff, so they know who can provide who can help them with different skills to learn. And I think an important slide on the bottom I would highlight is the question, I will apply to Interior Health for a job in my area of study. In 2022, only 42% of respondents said they would look for a job in their chosen study within Interior Health, and now we're up to 75%. So that's a lot of hard work with working collaboratively with TRU and efforts we're putting at the site to make a big difference, to keep those nurses that are training in our community to stay in our community. And that was really it, just a kind of overall snapshot of where we're at with the lay of land. Staffing is getting better. Obviously, as I said, the rural sites are still struggling, but we are doing everything we can to improve staffing and improve care for our patients.
Thank you for that. On the speakers list, I have Directors Bass, Sarai, Stamer, Smith, Grenier, and Thorpe. I'm gonna say Tricia, Thorpe, Director Thorpe. So Director Bass.
Thank you. I'm just curious, and this is probably a dumb question, but in terms of your visits to the emergency department, can you quantify how many people go through there who really should be seeing a doctor but don't have one? Like even a rough estimate of how much of the system is being bogged down?
Yeah, I think it's hard to speak to. I know that, if Lisa and now Kathy Dool, her replacement, they could have some UPCC numbers of how many people are going through the urgent primary care centers, and those numbers are going up. But I think, I don't have enough to tell my head. We could look at that. I think where the number of unattached people in our community is very high. So I think it's hard to quantify how many. I think we can look at something called the CTAS score. That's how acute their illness is. With a 4 or 5 is lower need. Those could often be seen in a walk-in clinic or urgent primary care center. And We are seeing those numbers go up, but we are seeing them also go to other areas. And I know we saw STEPS talk earlier, they help. The Urgent Primary Care Center helps. Also, the North Shore will make a difference. So those things will make a difference to those numbers coming in.
Thank you, Director Stamer.
Thank you, Mr. Chair. Yeah, Director Bass kind of stole my thunder on that. Thanks for your presentation, but can we just get a little bit more clarification on that maybe at our next meeting? Because I think it should be quite easy for you to be able to distinguish whether something's life-threatening and not, and whether it's something that should be seen on a walk-in clinic that we don't have. I mean, it's great that STEP was here, and it sure opened my eyes on a bunch of different opportunities that have been going on in some of the communities in our region. But honestly, it doesn't help when we don't have walk-in clinics in Kamloops. We don't have a walk-in clinic in Barrier. We have limited access in Clearwater. It would sure be nice to be able to see when those numbers get broke down, what are really emergencies and what aren't. Thank
Yeah,
you.
absolutely. Can bring it to the next meeting.
Thank you, Director Sarai.
Thank you, Chair. Just a couple of questions and a comment. You showed that one slide of the wait times, it was high in 2022, now it's at 25 hours. Is that an average in the province of a regional hospital? Is that a normal wait time?
If looking at interior health, for a large center, we're actually doing the best. Kelowna General is actually higher than that, and we're doing better. And there's a lot of initiatives we've done as far as getting patients to the floors earlier. Unfortunately, it does sometimes mean patients getting care in hallways, but that allows the emergency room to do the space for those 228 patients that are coming through to do that. And we try to keep them there as shortly as possible, but allowing Emerge the space to do the work and pulling through the unit spreads those patients through multiple units rather than being in one congested area. And we'll continue that work even when the new emergency department opens, because we have extra space doesn't mean we want it filled with inpatients. We need to make sure emergency room can do the emergency work they do to care for the patients that need it.
Supplemental, thank you for that. The other question, you showed the 47, the number of RNs coming into hospital. It's great to see the local TRU nurse school, the number 47. Is that a high rate finally this year, or is that a normal rate? Because in years past, we've heard that we couldn't retain nurses from TRU. They would go somewhere else because of the atmosphere or what was happening at the hospital. So what has changed? Are we actually going to TRU and selling Royal Inland Hospital, or is the relationship just better?
Yeah, I think this is probably the highest we've hired in a year. Like I said, last year, the same time period, we only hired 38, and this year we hired 61. I think it has a lot to the culture. Like I said, it sounds silly, but something is silly. Something is referring someone to as their name rather than student or this, that changes the culture. I think the culture in the building is different, and this, like, you can do better work when you're happy when you're there. And we were doing a lot of work to change that culture, to have positivity, to talk about the good things, not dwell on the negative. And, it was really hard a couple of years ago. It was hard coming to work every day for every person in that building. We are in a much better spot today, and that is showing people when they feel comfortable and happy in a spot, they will want to stay there and continue there. And we're all committed to continuing that work to changing that and make sure people feel comfortable no matter what they come in, whether a student or a visitor or someone from one of our local schools that are coming as a shadow shift. We want to make sure that they want to come and stay here, because that's what we need to make our community strong.
So just my last comment, and I'll make it really short. So what I'm hearing in past was we're pulling nurses away from their departments to fill in other departments. And I think that's where you're alluding to. Nobody knew their name because they weren't from that department. So if we plugged that hole and we're keeping nurses where they belong.
Yeah, that makes a big difference. And it's one of those positive snowballs. The more staff we have, the less we have to share them between the building. And every new nurse makes a difference, probably 10 times what their one position does, because every time someone is on a unit that doesn't have to be pulled somewhere else, we need to do that. And we have to balance that with patient care. And we can't have, one unit where we have only a few nurses, now we have many. We have to balance that, and we try to be very cautious, but we have made a concerted effort to keep them in the unit they applied for, and they stay there. So thank you for that.
Thank you, Director Smith. R. Smith.
Thank you. Thank you, Chair. I just noticed that Logan Lake wasn't actually in your rural report either. So I'm feeling a little bit like we may not be on your radar. And surprisingly, things aren't terrible for Logan Lake right now. They've improved significantly probably from where we have been for some time. I think it's probably more of a good news story. But I just want to make sure that we don't fall off your radar because we do have some really good things happening. The management has probably better communication now than we've had for a really long time, but please don't forget us.
And I do apologize. I only oversee Royal Inland, so I have a very kind of focused view and reports. I had a few updates from my other partners and unfortunately couldn't be here, but I assume they will be here next time to speak to Logan Lake and other sites.
Thank you, Director Onslow.
Thank you for this, that you have said you basically focus on the Royal Inland or oversee that. So this is a comment about Blue River, but on your slide, it had said that the nursing position had been filled. Yet during this meeting, I just received notification that we are again closed because we don't have a nurse, and this is week 8 that it's happened. So I appreciate that Blue River was on the slide, but I also would like the lens to shine on our rural community that we are not getting any nursing staff right now because of holidays, et cetera, and struggles that you've had in Clearwater. But the trickle down effect is that Blue River is left with a vacant hole. And we are 116 kilometers away from the nearest healthcare facility, and it is a huge challenge for our community. So hopefully that position is getting filled with a regular staff member. And we have been working with your executive director as well. But anyway, thank you for that. And unfortunately, it takes a little bit of time for the person to actually start. So but thank you very much for your comments and very much here.
Thank you, Director Grenier.
My question was answered.
Thank you, Director Thorpe.
Thank you, Chair. This one sort of follows Director Sarai. I want to ask you about your emergency department. I'm really happy to hear that you've got more recruits and you've got more nurses coming in. But what's happening in the emergency department? My understanding is that you're having to bring in nurses from other interior health sites. And I know of one incident in May where you had 2 out of the required 5 nurses on a night shift. So what's being done to address the staffing issues in the emergency department at RH?
Yeah, so yes, we do have nurses working for other areas. We have agency nurses. We have areas, nurses coming from other spaces, just as we try to help that out. There is still a shortage. I would say our 2 biggest pinch points are the emergency department and our intensive care unit right now, the specialty nurses. So these are frontline nurses. They'll hopefully move into that. I can say that through a lot of work for the emergency department managers that we have new nurses going through school right now there's extra education required to be an emergency nurse. So 5 just went through in January that are now finished. So we are seeing as well an uptick in those areas. Those aren't new to the health authority. Those are people within the health authority that are being trained to be an emergency. We've tried to fill the gaps with other staff. So we have more licensed practical nurses working in that area now to support a different more care aides. So we try to mitigate with other people that have different roles that can support RNs to do their position, but it is definitely still an area of need. And we're, again, working on the culture. The new emergency department will be a big draw for staff to be able to want to come into work in that space. So lots of those things are going into it, as well as the culture and making sure people are willing to go there. We've created some positions that are entry-level positions, so like a med surg nurse rather than an emergency room nurse, so then they can do the care that they can for the inpatients, the people being held there, and allow the emergency nurses to do their specialized care. So we're doing lots of different tactics to have enough people there. They may not be specific emergency trained nurses, but they can do other things to allow those nurses to focus on the higher level cares they have to.
Perfect. Thank you. I have Director Hamer Jackson and Director Hall to close. Director Hamer Jackson.
Yeah, my question is on staffing again, and right or wrong, I don't know who's right or wrong, whether British Columbia is right and the rest of the country is wrong. But I'm just wondering if there's been any, due to restrictions of doctors and nurses with the COVID situation. I'm just wondering if there's been any studies or any uptick in any COVID cases in other provinces around Canada, due to nurses and doctors going back to work in areas like, has there been any serious COVID update, cases happening in these facilities around the country?
So, sorry, I'll just chime in, and this is would be a directive from the public health officer, Dr. Bonnie Henry, to take people that are vaccinated or unvaccinated. This isn't anybody in this room, whether it's a director or any of the staff that are here present from Interior Health to answer those questions. So I will continue on the speaker list. Director Hall,
Thank you.
I just, can I supplementary?
if it's not related.
Yeah, just all I'm asking if there's been any studies that you know of.
Not off the top of my head, sorry.
Thank you, Director Hall.
Thank you. Thanks for the presentation and the staffing and that. And it's great to see the uptake on the amount of nurses that are coming in. I think it was 61 and 47 of those coming from TRU, and that's a huge improvement over your years past. I think TRU uptake is about 82 to 88 students a year. So we're just around 50% of the students retaining and staying within our community, which is a lot better than what it was. My question is, with respect to agency nurses, are you seeing more demand within the Thompson or within the TNRD with the amount of lines that are down? Yeah, I think kind of like Heather about the question around shuffling staff. I think we're repositioning some of the agency nurses to sites that need it, that we're having the closure. So I know Merit is using quite a few, where RH is maybe using less. We always want to use our own staff. Agency nurses are a Band-Aid solution. We're very aware of that, and that's not our intention to continue that. And as one site, as RH gets more staff, then they can spread them to other sites and hopefully keep them open. So we try to be strategic in how we're using those, and being a bit more restrictive in how the agencies can operate. And the ministry, the province is working on that too, to clean up that a bit. But we are seeing the usage still in Interior Health, but it is moving between different sites to hopefully fill some of the gaps.
Thank you. With no further speakers, I'd like to thank you on behalf of, so I'm sorry, we have one person online. We have Director Birch Jones.
Thank you. And it's really just a comment that for a number of reasons and some misfortune, I seem to have spent quite a bit of time in the emergency department in the Royal Inland Hospital in the last year or so. And there's really some fantastic staff, the doctors and the nurses, but it's hard to watch them, particularly the nurses, just running. And it does get very demoralizing for them over time when they can't do as good of a job as they'd like to. So I'm heartened by the improvement in your numbers, and just keep it up, because just by having better levels of staffing, that's an amazing recruitment tool right there in itself. So thank you.
Thank you.
One more director. I think it's going to be a short one, right, Director Helton?
Very short. I just want to share a good news story. The one and only brother I've got was scheduled to be in Kelowna to have his eye removed, and it was infected into the back of his head. And he phoned me quite a while before that. He says, "Doug, I can't take this pain anymore. Get me an ambulance or get me to the hospital." So I happened to be in town. I phoned 911. I met the ambulance at Knutsford Hall and took him up to his house, and they took him to the emergency department. He's one of those cases that you had up there on the wall, and they give him some medication, and the doctors on duty there referred him to another eye specialist in downtown on St. Paul. Won't say any names. I took him there the following day. He took one look at him and said, "You need help, man." And 24 hours later, I had him in the surgeons at Kelowna Sister Hospital in Kelowna, and removed his eye and all the infect stuff that goes with it, and got him scheduled to have a replacement eye in Burnaby here in 3 weeks. So I just want to share a good news story. And it's all started in your ER department. Thank you.
Thank you for sharing that, Director Helton. And as I was saying, on behalf of the board, thank you for the very detailed reports today, and really on behalf of us, but also our residents. And I look forward to doing this in future board meetings. So thank you. As we stand on the agenda, we have had 6.1 move directly below 7.1. So we will move. There's 3 recommendations in front of us. Moved by Director Stamer, second by Director Smith. All in favor? Opposed, if any?
Aye.
Thank you. I see everybody online waving. I'm good with that. We have a second, moved by Director Blackwell, second by Director Sarai. All in favor? Contrary minded? Thank you. Director Birch Jones? Favor? Thank you. And we have a third recommendation. Moved by Director Newstater, second by Director R. Smith. All in favor? Contrary minded? Thank you. We will go to 7.2, the CAO report.
The report's coming from Corbin, so I'll pitch it over to him.
Yeah, thank you, Chair, and through to the board. Just a quick update on the Cancer Won't Wait campaign. I think this will be one of the last times that I'll be able to speak to the board on behalf of the campaign before it concludes in mid-September of this year. Patient stories are now live. So the proponents that the regional hospital district has acquired to sort of run the campaign have collected a number of patient stories, those who have direct experience with cancer care or the lack thereof within the Thompson region. Those are now live on cancerwon'twait.ca, and of course, we encourage all directors to share those on your respective social medias. The campaign will have a booth at Rib Fest in Riverside Park here in Kamloops, August 9th, 10th, and 11th from 11 a.m. to 9 p.m. In the Family Fun Zone. We, of course, encourage all of you to stop by if you're planning on attending Rib Fest. And if you're interested in volunteering at the booth, please let me know and we'll be able to schedule you in. Obviously, it won't be a huge time commitment, and I'm sure that we can find a way for you to get some ribs in there as well. Following Rib Fest, the campaign will be coming to a close, especially in preparation for the fall provincial election. However, messaging will be shared to keep residents and voters engaged on the importance of the Kamloops Cancer Centre, likely in ways of sort of a election toolkit that folks will be able to use, respecting the those who are running in the provincial election and their commitments to the Kamloops Cancer Centre. That is really it. I'm not sure if there's any questions from directors, but just wanting to share a brief update.
Thank you for the update. I see no discussion. We'll move on to 7.3, the Financial Information Act disclosures. There's a recommendation. Moved by Councillor Bass, second by Director Bass, Director Blackwell. All in favor? Contrary minded? Thank you. Okay, for new business, I just want to close today by saying this was a good day for healthcare in the Thompson Regional Health District. And our residents deserve this, and they've deserved it for a very long time. This was a big step forward. We know that it's not the end. And as we've heard, and I've heard loud and clear from the board today, that there are some questions of how the Cancer Centre will operate when it happens. And I don't think I need a formal recommendation, but I will be taking the concerns that we've heard today and throughout conversations through to BC Cancer and Interior Health through our quarterly meetings and annual meetings with CEO Susan Brown. But at the end of the day, the whole region won today. And we can't forget at the beginning and prior to the presentation from Interior Health of the cost overrun of the emergency room of about $18 million that was not borne by the taxpayers of the RHD. So it was good. On that note, I'm going to adjourn the meeting. Thank you.